Hello, everyone. Welcome and thank you for joining us for today's session, Frequently Asked Questions on Understanding Bispecifics. I'm Veronica Bohorquez-Medd, Senior Manager of Community Education and Engagement at the Multiple Myeloma Research Foundation. I'm joined today by a great panel, Dr. Cindy Varga and Ms. Jordan Robinson from Atrium Health Levine Cancer Institute in Charlotte, North Carolina, and Kim Odom, a multiple myeloma patient living in Asheville, North Carolina. The MMRF recently hosted a webinar giving an overview of bispecific antibody therapy for multiple myeloma and today's live stream. So today's live stream will be a continuation of that discussion with more opportunity to answer to more questions, especially as listeners and viewers are submitting questions in the chat for today. So for more on the basics of bispecific therapy, you can watch a recording of our most recent webinar that was about 2 weeks ago and review other bispecific therapy material under the Education Resource Hub on our website at themmrf.org. So let's dive into today's live stream. Dr. Varga, I will start with you. While we wait for our listeners to submit their questions, can you discuss what you consider giving bispecifics, or can you discuss when you consider giving bispecifics to a myeloma patient?
Yeah, usually we will reserve a bispecific antibody for patients who typically have been exposed to a what we call immunomodulator, which is lenalidomide or pomalidomide. The commercial name is Pomalyst or Revlimid. If a patient has also been exposed to a proteasome inhibitor, so bortezomib or Velcade, carfilzomib or Caprolus, and a anti-CD38 monoclonal antibody such as daratumumab or isatuximab. So it's really for patients who've seen quite a bit of therapy in the past, who have been exposed to each of those classes of drugs and likely has either not tolerated them or have become refractory to them. That's typically who we consider a bispecific antibody for. Sometimes we'll use bispecific antibodies for bridging therapy for CAR-T, which we could talk about later, and sometimes we'll use it in place of CAR-T if we feel like a patient isn't a candidate for CAR-T. So sometimes it can substitute for CAR-T as well.
Great. Thank you, Dr. Varga. So I think that's a really good segue in terms of listing out the previous kind of classes of drugs that patients are exposed to before they're about to go on bispecific antibody therapy. So that brings me to my next question. Jordan, bispecifics are available after 4 prior lines of therapy. So can you explain what a line of therapy is?
Sure. So a line of therapy is going to be kind of how we think about the combinations of the treatments that Dr. Varga was just talking about. Most of the time in the upfront setting, we're using a combination of 3 or 4 of the medications at one time. And even though you're getting multiple therapies in one setting, that is still considered one line of therapy. So a line of therapy is kind of the combination of the treatments that we're giving at a specific time point.
Oh, great. And so there seems to, there's clearly timing and there's a lot of kind of logistics to these pieces. Dr. Varga, so bispecific therapy, as you were mentioning previously, is given to patients who have already been through prior lines of therapy. So maybe you can go into a little bit more detail, perhaps, of why it's often used later in the treatment journey.
Yeah, well, we feel that patients who've seen lots of lines of therapy, specifically in those 3 classes that I had mentioned, the anti-CD38 monoclonal antibody, proteasome inhibitor, and immunomodulator, those are, our best therapies that we use in earlier lines of therapy. But if patients have failed those therapies, prognosis is really poor. So before we had bispecific antibodies, before we had CAR-T therapy, there were not many options for these patients, and they did pretty poorly. We didn't have lots of great, drugs to give them. With the advent of these newer therapies, like the bispecific antibodies, we're seeing response rates that are just so impressive, even in these heavily pretreated patients. So we do need these drugs for options for patients who've seen, our classic therapies that we've been using, and rescue them and get them into remissions again. So, right now they're reserved for later lines of therapy. There are clinical trials right now looking at bringing these bispecifics to earlier lines of therapy. For example, 1 or more prior lines of therapy. There's, clinical trials looking at these drugs in frontline therapy. So, once something works in relapse refractory late line, we always like to bring it closer to frontline to see how they fare. So that's right now, undergoing investigation. But for now, we are reserving this class of drug, the bispecific antibodies, for patients who've seen and are refractory to those 3 classes of medications I mentioned.
Great. So that kind of brings me to, again, as we're weaving sort of the complexity of bispecific antibody therapy, would you kind of, as an add-on to that, do bispecifics work for patients that tend to have more aggressive forms of myeloma? Perhaps if they're resistant to drug-resistant disease or certain mutations or features like maybe extramedullary disease or tumors outside the bone marrow?
So that's a really good question. What we do know is that bispecific antibodies are a really great novel, drug that we're using in these relapsed patients. We know that patients who have high-risk disease, so I know you asked about aggressive disease, but patients who have high-risk disease, so those, we can look at the cytogenetics of the actual myeloma, and we know that we can classify some patients as high risk if they have certain mutations. So we know that even high-risk patients will respond. They might not respond as well as someone who has standard risk myeloma. And if they do respond, they might not respond as long as someone who has, standard risk myeloma. So I would still give these agents to patients who have high-risk disease. Now, for patients who have extramedullary disease, so disease outside the bone marrow, that is considered a high-risk feature. I would say the same thing, that these patients can respond, likely less so than standard risk. But what's really exciting is that there's a clinical trial called the Redirect clinical trial, where they took the 2 bispecific antibodies and put them together. So one of them, for example, targeted BCMA, which is a protein on the myeloma, and the other one, GPRC5D. And they kind of gave them at the same time, specifically in a subgroup of patients with extramedullary disease, and they did really well with targeting with both bispecifics. So it's recognizing that these are a higher risk patient population, and they used, they tried to go about it in a outside the box fashion by using both, targets, and they did really well. Their overall response rate was, at 60%, something like around that range, and they did quite well with a complete response rate in about a third of patients. So for the extramedullary disease, yes, we do use these agents. For rapidly rising relapse disease, it's a little bit of a different story. I probably wouldn't use a bispecific if you have someone in front of you who is having very aggressive, large burden relapse, because chances are we won't make a dent by using a bispecific. So what typically I do, and some other myeloma doctors do, is debulk these patients with old-fashioned chemotherapy. And once they're debulked, then start them on a bispecific, and they tend to do quite well that
way. Great. Thank you for that really helpful breakdown, especially. I think, I'm already seeing kind of some really good questions in the chat for later, especially at kind of what certain points, maybe if you're on maintenance and so on. So we'll definitely get to that. Kim, as being our patient here on this panel, would love to hear, can you tell us at what point in your treatment journey did you begin taking bispecific therapy?
Well, I was originally diagnosed in 2009. Did I can't even remember what it was, Velcade and all that good stuff to get me to almost remission before my first stem cell transplant in 2010. Was in remission for that for about a year with no maintenance therapy. Then, of course, I had relapses every year, 2 years ever since, did different, lines of treatment. 2017, I did my second stem cell transplant. Then in 2023, I started with the teclistamab. And I've been in remission since. I also have osteonecrosis of the jaw, thanks to Zometa. Other than that, the difficult stem cell transplants, I really suffered more with the nausea and fatigue for several months, but after that, I felt great. Teclistamab, no side effects whatsoever. The worst part of teclistamab is when your IgG levels go down. You get to have the lovely IVIG treatments, which pre-meds for that are Benadryl and Dex. Dex is my arch nemesis, which is probably the same for all of multiple myeloma patients. But I tolerate it well. Pre-meds for IVIG are, they did it once without it. I had severe side effects. They stopped it, gave me my pre-meds, and I'm fine. But as for the teclistamab, 2 years going strong, and really no side effects that I can even think of. So I'm happy. I think Dr. Varga's happy, and I'm just trucking along with life. Been doing this for 16 years, so.
Thank you, Kim. That's incredible to hear, and we'll definitely dive into a lot more. We'll look into side effects, into access, and you have a really great story to share even more in terms of access to bispecifics too. So thank you for sharing that. Let's pivot over to access and the treatment process. So Dr. Varga, this is for you. What type of centers provide bispecific therapy, and how can patients find a cancer center with experience for myeloma specialists in treating patients with bispecific antibody therapy?
That's a great question. And I think it's something that is going to change, I think, over the next, say 5 years or so. Right now, the bispecifics need step-up dosing because of their unique side effect profile that they have, at least early on when we administer the drug. There's something called cytokine release syndrome and neurotoxicity that we monitor for with these step-up doses. And so they require 48-hour observation periods with each step-up dose. Usually there's about 2 step-up doses prior to a full dose. At the moment, it's really centers that have experience with these T-cell redirecting therapies that are administering these step-up doses. And so usually these are more like academic centers that, have a lot of experience because they've run the clinical trials that have led to the FDA approvals of these drugs. So I would say, usually these big cancer centers, NCI designated centers, all of these centers are probably a fair bet that they're going to have experience giving bispecific antibodies. I think that other resources to find out what centers offer it is just ask your local oncologist. If they cannot give step-up dosing, they will know who to reach out to and who to refer you to. You can also do a search, online on clinicaltrials.gov. Look at places that have used these drugs in clinical trials. Those places will sure to have experience giving bispecific antibodies. Good, patient references like MMRF obviously is a good place. Speaking to other myeloma, patients who've received these drugs, you'll get a good answer to those questions. So there's lots of resources, and I'm sure we can offer or drop in the chat, places where people can find out in their areas where they can get access to bispecific antibodies. The reason I said that in the next 5 years it might change is that we're actively trying to get easier access to these bispecific antibodies in the community. So you don't have to travel into, very metropolitan areas where there's traffic and parking issues and, inconveniences. So the goal is that we're going to decentralize these processes over time. And that's, I'm actively trying to make that a reality.
If I could just dive in real quick. I live currently in Asheville, North Carolina. I've been, going down to see Dr. Varga for years and years. And that's where I initially got my step-up dose. Had the treatment, I believe it was once a week, then went every other 2 weeks, and now I'm once a month. And I was going down there to have those treatments, and then found a doctor here in Asheville, Pardee Cancer Center, Dr. Tremont, who does do it here in Asheville. So it's important to ask your doctors. Even in Little Asheville, they do give teclistamab, and for not having to drive down to Charlotte every month is huge because it's about a 2-hour drive. So just be sure to reach out to your oncologist, search around in your community, see if anyone's doing it. And I've gotten very lucky to be able to remain here in Asheville, and I go see Dr. Varga every 3 months for follow-up. So
fantastic. Well, it sounds great and really promising, at least, trying to meet the demand and ensure that quality of life for patients can be sustainable while they're taking bispecific antibody therapy. Thank you, Kim, for that insight too. We're definitely going to dive into more of that as well. But and Dr. Varga, thanks for kind of walking us through just that process, what patients can do. You talked about dosing, and dosing is potential. It's a topic of discussion, at least for bispecific antibody therapy. There's different approaches. So can you walk us through what the typical treatment frequency is like for bispecific therapy, and is it standard for all patients, or does it vary, and is it usually given in inpatient or outpatient settings?
Oh my God, that's a big question. Okay. So if we break it down, if we break it down to frequency of dosing, so the label dictates that it should be given on a weekly basis, and then after about 6 months, if you're I shouldn't say after 6 months. If you've been in a complete remission for 6 months or more, then it could go to every other week. That's what the label states. I think people are doing various things. I think people are recognizing some of the side effects. To Kim's point, she had mentioned her IgG levels going down. We know that patients can get infections on this drug. And so what I know a large proportion of myeloma doctors are doing to mitigate that infection risk is to give weekly dosing for only a couple of months, and then switch to every other week dosing for another 4 months. And then at after 6 months of therapy, so cycle 7 and beyond, to go on a monthly basis if we're talking about, teclistamab, which is one of the bispecifics. The other bispecific that is frequently administered is the talquetamab, and that is given every other week. And we usually keep people consistently on that unless there's toxicities, in which case we can even move it to once monthly. And remind me what your other question was. Something about inpatient or outpatient. Was that the question? Okay.
Yeah.
Because I mentioned a little earlier that there's a particular side effect that we're monitoring for with the step-up dosing, and that's the cytokine release syndrome, which is this kind of inflammatory response to the bispecific activating the T cells to attack the myeloma. These T cells, when they get activated, they release cytokines. It can cause fevers, it can cause blood pressure changes, and it can even cause, rarely, some neurotoxicity, which can manifest as a little bit of confusion, not being as sharp. And so, these have to be treated and addressed. So, typically we give a step-up dose, monitor for 48 hours, another step-up dose, monitor for 48 hours, and then give the treatment dose and monitor for 48 hours. That is usually given inpatient. The drug is given outpatient, but the patients are monitored inpatient. Here at Levine Cancer Institute, we can do both inpatient and outpatient monitoring. So for our outpatient monitoring model, patients basically get their injection of their bispecific in the infusion center, and then they go home, and we have a hospital at home program where there are folks that meet these patients at home and give them a kit that composes of a blood pressure cuff, something to monitor their heart rate, their body temperature, their oxygen levels. They're given a tablet to input their vital signs every 4 hours, and there is someone monitoring their vital signs 24/7. There is a nurse that's there. We also have virtual visits on a daily basis with internists or oncologists who are obviously trained in giving bispecific antibodies, and we have medics that come to the home between step-up doses to check in on patients, make sure there's no neurotoxicity. And if patients develop a fever, they have a triage system that they can call, and they're told what to do in those situations. So we're very lucky at LCI. I'm sure Jordan can attest to that. We've had great success with this program where patients can stay home and get their step-up dosing, but not all patients can do it. Unfortunately, they have to be a specific distance from our main hub to get interventions if we end up having more higher grade complications. So patients who live too far away or don't have a caregiver to stay with them at home to monitor them for these side effects have to go in to the hospital for the 48-hour monitoring after every step-up dose. long-winded answer to a small question.
No, that's really helpful. I mean, I'm sure this is kind of pivots actually to my next question, over to Kim too. And Kim, you mentioned how you were on Tech Valley and you were changing, you ended up being able to change and find a local oncologist to get more of your dosing.
Right.
And Dr. Varga really explained kind of, these pieces in terms of different environments, or at least different support systems too, or resources that the hospital can give you if you won't be, if you're not close or if you're not, ways to monitor. So that's really important. Kim, can you share when you were starting to receive Tech Valley closer to home? And I know you mentioned that you found your local oncologist and you were able to ask questions. Can you share us with the audience a little bit more how you navigated through this process, and maybe when at one point in your treatment you were able to kind of make that pivot?
Oh gosh, I'm trying to think. I think it was probably maybe 7 or 8 months in. I'm not sure. I'd have to check my records. But I was talking to my oncologist previously locally here, and they were trying to get, there's an approval process that the doctors have to get in order to be able to get teclistamab. And my oncologist locally here could not get approved. And actually, I had a friend getting treatment at Pardee, and she goes, well, why don't you ask someone at Pardee? And then I had mentioned that to Dr. Varga, and then hence why I got in contact with Pardee and Dr. Tremont. And within a week, I was in there and getting my teclistamab. It's a huge relief knowing that I only have to drive 15 minutes to get it and not down, 2.5 hours, even though we'd love to see Dr. Varga every month. Having it
I don't take offense, Kim.
Having it close here with any complications, it's just so nice to be able to go 15 minutes from home and get the IVIG, and then go home and life is good. But I had to do a little bit of research because 2.5 hours there for a shot that takes maybe a half hour. By the time you get your blood work done, they come back and say, yeah, you're good to go. The pharmacy makes it and you get your shot. You're talking maybe an hour. 2.5 hour drive for an hour visit, and 2.5 hours back I was getting fatigued. It's a lot. And then to have someone to drive you down there and all of that, it was getting to be a bit much. If I would have had to do it, clearly I would have done it, but finding someone here locally in Nashville was a lifesaver for me. You just have to do your homework. Have to do your homework with the doctors.
You got yours pretty early on. And that's why there weren't that many, community sites that were REMS certified to give it. Now it's a different story. Now it's a lot easier to find these sites. But you're right. When you were first started on it, it was pretty early on.
Right, because I was I was started on it, I think it was in March or May of 2023, and that October of 22 is when it was approved with the FDA. So I was, I wouldn't say one of the first, but it was very early on after it got approved that I started, and I'm 2 years in now. So it worked out great.
Oh, that's great. Thank you. No, they're really, really great takeaways for our patients and for our audience. Speaking of access and, managing and, having to, navigate approval and coverage, Jordan, this brings my next question over to you. What do you typically tell patients when they ask about insurance or potentially Medicare coverage or just costs in general when they know they're about to have to start taking bispecific therapy? Are there any resources or potential advice or insight that could be helpful for patients as they're walking through this?
Yeah, so I always make sure to tell people that we will check with your insurance before we even think about starting to dose it, because I think it can be very overwhelming to think about the cost associated with these kinds of treatments, especially at the beginning with the frequency that we're giving it. So we certainly always check with insurance before we dose it at all. From a Medicare perspective, I don't think that there have been any issues with coverage. And I think generally with some of the commercial insurances, because all things considered, it's still relatively new treatment, and because of the stipulations of, when we give it after these multiple other treatments and lines of therapies that we've been talking about, sometimes if we're trying to kind of navigate it or fit it into a space that may not be, black and white, what it's indicated for, I think oftentimes if one of us in the clinic is able to speak to the insurance company and kind of give them a real person situation, explain what's going on and why we're using it. I think we generally are able to get things covered. And then for other resources, the manufacturing company has resources to help if there's gaps in coverage or if there's any other patient assistance that's needed. We have contacts with those companies, and then of course they have their websites, and patients can reach out through those as well if there are any kind of breakdowns or things that are lacking.
Fantastic. Thank you. Thank you for walking us through that. No, great. We received a lot of those questions, at least on our webinar, a lot of, in just investigative questions about insurance, navigating. So good to know that there's, processes in place to set up patients for success in that way. All right, let's pivot over a little bit to just more about bispecific effectiveness. So Dr. Varga, can you walk us through how long it takes for bispecific therapy to start working, and what should patients look out for during that time?
It works pretty quickly. I would say in that first month, we're going to see significant response. I have to tell you, for some patients, I've even seen patients achieve a very good partial response or complete response by that 1 month mark. So it really depends. But that first month, you'll know if the drug is working or not. In terms of side effects, there's different side effect profiles to the different bispecific antibodies. So, for example, for teclistamab and talquetamab, the cytokine release syndrome, neurotoxicity, those are the same side effects that we're going to monitor for with the step-up dosing. But once you're past the step-up dosing, they have different side effect profiles. For the teclistamab, it's mostly, related to infection. As Kim had mentioned, she has no side effects other than going in and get, mitigating strategies to reduce infections. So the risk of serious infection is pretty high with teclistamab if it's given every week. And it could be as high as in the 45% range. And when I say serious infection, meaning an infection that will land you in the hospital requiring IV antibiotics and whatnot. But I think the way that we're kind of adjusting the dosing schema of, every other week to monthly, giving IVIG, we also have patients on prophylactic medications, that has improved things tremendously from an infection standpoint. So those you will see over time, the infection. You won't see it immediately. It's really something that's cumulative, that as you stay on the drug for longer and longer, you have a higher risk of developing these infections. For the talquetamab, that has an interesting toxicity profile. It can affect the nails, it can affect the taste, it can affect the skin. And Jordan's smiling because she knows what I'm talking about. It's a very frustrating side effect profile. But those can happen in the first month. Patients will start to, usually it's the taste. I don't know if Jordan, you can concur, but usually when patients get it, the first month they'll start to say, starting to notice there's a metallic taste, there's things they're not tasting quite right. And then over time, not necessarily that those side effects go away, but they kind of get better as we find strategies to address them. And so I would say I haven't had many patients discontinue talquetamab because of those side effects. We've just found ways to keep patients on the drug because it benefits them so much. So those are, the side effects. So again, just to recap at the beginning, it's really in the first couple of weeks, it's the CRS and the neurotoxicity, and then later, long-term, we're looking more at infections, and then, the skin, taste, and nail side effects.
Great. So, and okay, that's great. Yeah, we see some questions too. Yeah, especially on other kind of drugs such as like talquetamab, how long it takes for things like side effects such as taste to return, and those pieces as well. Jordan, I guess my question for you is thank you for walking us through that, Dr. Varga. We've got some great questions in the chat that'll kind of keep going into that piece. Jordan, what do you tell patients when they're about to start going on bispecific antibody therapy and things that they should potentially look out for? Before they begin.
Yeah. So we definitely tell people, if anything is different, if it feels unusual or weird or something that's new, let us know. Even we have our pharmacy team do pretty thorough education before we start the drug, so patients will know kind of what to expect. But even if it's something that you didn't hear when you were taught about what to expect, if it's anything that's new, we want to know about it, and we can kind of parse through together whether or not we think it's related to the drug or something unrelated. But I think the main ones to look out for, like Dr. Varga said, the CRS and the neurotoxicity at the beginning. CRS things we're looking for are fevers, really is kind of the main thing. Dr. Varga mentioned we send people with blood pressure cuffs and that kind of thing. So if there's a drop in blood pressure, those are things that if they're in the hospital getting their step-up dose, of course, the hospital team is monitoring all of that. The hospital at home team is checking in on all of those vital signs. And we have patients kind of keeping logs and keeping track of that pretty closely in the outpatient setting. The neurotoxicity things can kind of vary widely, which is why we tell people to tell us if there's anything that's different. So even like persistent headaches that won't go away can sometimes be a mild form of that, all the way up to very significant confusion. We tell caregivers, this is part of why we have caregivers with them 24/7 if they're outpatient. If sometimes the patient receiving the drug may not notice too much different, but someone that's with you that knows you well can see if there's any changes in how you're thinking about things or the way that you're speaking, that kind of thing. So having someone with you to kind of be able to assess that is important. And then, the taste can happen pretty quickly, like Dr. Varga mentioned. So anything with that, we want to know. Dry mouth can kind of go along with it sometimes too, which makes it harder, I think, sometimes if your mouth is really dry and you're trying to just get something in, but you don't have any saliva to wash it down, it can be a tough one. So we tell people kind of all those things to watch out for. The skin peeling, usually on hands, like the palms of your hands or soles of the feet, and then the nail changes. The nails are usually more of a kind of cosmetic thing, but they can certainly be important because people, your hands are kind of out with you everywhere you're going. So it's something that I think people worry that other people will notice a lot too. So those are the things that we tell people about. Like I said, really anything that's different, we like to know about it.
If I could jump in too, and I forgot to mention, being on the teclistamab, and Dr. Varga, you can confirm this. I mean, I was put on Bactrim, and then of course I've always been on an antiviral, cyclovir, and I guess due to the fact that I'm on the Bactrim, that was given in order to, if there is an infection, it might, deter it from getting, worse than it is. Am I understanding that right, Dr. Varga? Just so patients know, even though you might not be at the point to get an IVIG and your numbers haven't gone low enough, you would still be on Bactrim. I'm assuming that's correct for most everyone.
Yeah, and the reason behind that is this is a different therapy than what most folks are used to, because we're using, T cells are really our first line of defense against cancer. So, we could be making cancer cells every day and our T cells are getting rid of them. But for patients who have myeloma, their myeloma has evaded their T cells. And so this is a very smart therapy in that it's using those T cells and kind of introducing those T cells to the myeloma as if they're courting, and they're basically saying, hey, you didn't notice this cell here. Let me introduce you. And the T cell all of a sudden sees it for the first time and gets activated, and then attacks. So what happens is it's such an excellent therapy that it'll wipe out your good plasma cells, your bad plasma cells. So that part of your immune system definitely gets suppressed. So your antibody producing cells get suppressed. But at the same time, your T cells are getting activated every time you dose patients. And eventually those T cells will get tired. And so now that's another part of your immune system that's being affected. So the Bactrim is there really to prevent what we call opportunistic infections. So infections that people who have a healthy immune system wouldn't be at risk for, but patients who have very suppressed immune system would be at risk for, such as PJP pneumonia. So that's what we're doing, Kim, is we're giving you medications to prevent those infections from developing. And then the acyclovir is there to prevent shingles, because that's something that patients are at risk for. And then the IVIG is, because all those plasma cells have been eliminated, is to really boost the immune system through passive antibody donation.
Right. Yeah, I just wanted to throw that out there so people
knew
that they would be taking, in addition to, when needing IVIG, they also would be taking daily acyclovir and Bactrim. So,
yeah.
Thank you. No, thank you, Dr. Varga. I think this is a really great segue, kind of as we're now kind of diving, a little bit deep into side effects. Kim, and especially as we're talking about kind of infections and these opportunistic pieces that can happen, Kim, you do receive IVIG to lower your risk of infection. So can you share what that experience is like for you, maybe including side effects, how you manage them? And we actually have a question in the chat, how often you take the injection.
Right. So IVIG, I'm getting it every 2 months. It just seems like with the teclistamab, that's when my IgG levels drop down to maybe 300. They've been as low as 280 something. And the site, how they give it, I usually get it the same day I get the teclistamab. Of course, they'll do my blood workup through my port. Then they'll check my, blood cell count, make sure I'm good to go with the teclistamab. And then they give me, usually they'll do the IVIG first, and they'll give me pre-meds of Benadryl and 8 wonderful milligrams of dexamethasone. I get to sit there and watch TV for about 30 minutes for that to take an effect. And then they'll start doing their bottles of the IVIG. And it usually takes about 2.5, maybe 3 hours. It depends on, I know they had given it to me once a little bit too fast. So I had side effects where I was really, really cold. My teeth were tearing. I felt like my heart was racing. Then they stopped it. They gave me more Dex, more Benadryl, and then they restarted it. And ever since then, we've gotten to a good dosage of how fast they want to give it to me, so I don't have any side effects. Really, the only side effects I have, of course, I'm tired because they give you Benadryl, so I'll probably take a nap for about an hour while I'm giving it. And then the typical side effects of dexamethasone. The day you get it, you feel great. Then you get your face flush. Then you hit the brick wall the next day. You're not sleeping well. But I usually get it on Tuesday. Tuesday's good. Wednesday, I'm just a little fatigued. Just know that I'm, have the side effect of the wonderful Dex. And then by Wednesday night and Thursday, I feel like nothing happened. So I've been fortunate. Now, whether I've just been through so much with multiple myeloma, I don't even notice my side effects or even want to notice them, because I have so much to do. I have 3 boys and husband, family, yard work, blah, 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 blah. So my whole thought process with the whole multiple myeloma is, I don't have time to worry about my side effects. And if my side effects are bad enough where my family knows I'm not getting up and cooking and I'm on the couch, then that means I'm really not feeling good. And I try to allow myself time to rest, but I don't want to take too much time, because then you can get into a funk and it can get into your head, and then you're starting to feel sorry for yourself and have your pity party. So I really just try to take the time that I think I need to get well, and then I bounce back, because I think dealing with the multiple myeloma, a lot of it is clearly physical, but a lot of it is as well psychological, and to be positive. When I was diagnosed, I Googled that I had 3 to 5 years to live and would not see my youngest to go to kindergarten. And 16 years later, I'm still here. Life is great.
Yay. That's great.
So, you just got to, multiple myeloma is not easy. You just got to, as I say, pull up your big girl panties and get to moving every day. That's just what you have to do. It's not a death, it's not a death. You're 16 years and here I am.
Incredible.
So,
No,
it's just part of life. You can't change it. So you just have to deal with it.
Thank you, Kim. That's very resilient and incredible perseverance for our patients to hear. So thank you for sharing that. Well, speaking of kind of these pieces too, talking about infections, talking about things to kind of monitor, control infections. Dr. Varga, I see we have a question in the chat. Does this affect, or is there any concern about patients' lymphocyte levels and potentially T cell fitness? And what can patients do, or what does that kind of discourse look like when maybe this is what a patient's profile is and they're about to go on bispecific antibody therapy, or does that affect eligibility in any way?
I don't think it would, having a baseline low lymphocyte count, it's not an absolute contraindication at all to going on a bispecific. But I think it'll open our eyes and be like, okay, the bispecific can, obviously, as I mentioned, through various mechanisms, suppress the immune system even more. So I think it's just the same mitigation strategies that we talked about, probably giving the T cells a chance to recover. So by spacing out the dosing, as I mentioned, we allow those T cells to not get as exhausted. So even if they have, coming in with low T cells, whatever T cells they have, we want to let them recover. IVIG, the Bactrim, the acyclovir, or the valacyclovir, like all those strategies remain the same. We wouldn't change anything just based on, lymphocyte or absolute lymphocyte levels per se.
Okay, great. No, excellent. Great. As I try to kind of keep to ensure we cover all of our topics for time here today too. Let's go a little bit. I'm seeing some questions in the chat too about CAR T. So let's kind of scale back a little bit. Dr. Varga, could you provide just a brief overview of the differences between CAR T cell therapy and bispecific antibodies? How maybe the differences between they're given. I think we often hear these two therapies being compared and patients kind of associate the two. So can you talk a little bit about perhaps why they sometimes end up being bulked together and patients seem to have to navigate between one or the other?
Yeah, they're all under the umbrella of T cell redirecting therapies. They both leverage T cells to attack the multiple myeloma. How they do so is a little different. So if we are focusing on the bispecific, I kind of explain the mechanism of action. The drug basically is like a dating app that brings the T cell close to the myeloma cell in proximity. The T cell gets activated by that close proximity. The bispecific antibody, though, is what brings them together, and how it does so is that on one side of the antibody, it recognizes an antigen or a molecule on the myeloma surface called BCMA, and on the other side, it recognizes a molecule called CD3, which is on the T cell, and that's how it brings the two together. For CAR T, it's a little bit different. So with the bispecific, as mentioned, you have to come to the infusion center and get an injection, on a fixed schedule, right? For CAR T, it's a little different. CAR T patients will remember this when they had their stem cell transplant. They went on a machine called an apheresis machine. So the machine is programmed to select out specific cells. When patients did it for a stem cell transplant, it was stem cells that the apheresis machine took out. For CAR T, it's T cells that are taken out. And then these T cells are sent to a special place where they're kind of engineered to become the perfect soldiers. What essentially happens is we choose a DNA sequence of interest, and using what's called a lentivirus, we're able to put that DNA of interest into the DNA of the T cells, and it allows the T cell, it changes the whole, building blocks of the T cells in terms of DNA, and it tells the T cell to make a CAR on its surface, a chimeric antigen receptor. That CAR is going to recognize a similar target to what the bispecific recognizes, which is called BCMA on the myeloma cell. And now we've made these perfect, soldiers against specific targets only found on plasma cells. And the lab will expand these T cells. So now we're making a whole army of these soldiers. And then they get shipped back to us. And then we give patients 3 days of chemotherapy, very light chemotherapy, to optimize the environment in the body to accept the CAR T cells that we're going to infuse in. And then it's a one and done deal. You get the CAR T cells and you don't get further therapy afterwards. So patients can remain off therapy for a very long time. It's not a cure, but we just got results back from what's called the CARTITUDE-1 trial, which was the pivotal trial that showed how effective CAR T cells can be. And in the most recent update, a third of patients remain disease-free even 5 years out without being on any therapy. So both the CAR T cell and the bispecific can have the ability to lead to cytokine release syndrome and neurotoxicity because those T cells are getting activated, obviously in different ways. But the CAR T cell has the ability to have higher grades of these complications. And so they can also lead to low blood counts because of the chemo that we give in advance. And sometimes all the inflammation that can happen with CAR T, patients can have low blood counts for quite a while. So it's a little bit different between the two. And even though bispecifics can have, are very effective and the overall response rates are quite high, the CAR T cell therapy can have even deeper responses. So, for example, the Carvykti product, which is one of the commercial products that we use, has a complete response rate in the 85% range, which is incredible, and it can last for a very long time. So, the nuances between choosing between one and the other are that, sometimes it's just a matter of the FDA indication. So CAR T is now, we can give it in second line. So bispecifics, it's only 4 more prior lines. So it just happens to be that most patients will get CAR T before bispecifics. But sometimes it's also a factor of if a patient can't wait for that manufacturing time when we're engineering the T cells because their disease just is refractory to everything and we need something fast, then we will reach for a bispecific antibody in those cases.
And that was pretty much the reason why I chose the biospecific versus the CAR T cell. Was I was just ready to, my InSpike, it was showing, that the disease was no longer in remission. And I was like, no, I want to get it nicked in the butt real quick. And I didn't want to wait. So that's the only reason I chose the biospecific versus the CAR T. So
yeah, and just to kind of expand on that, the engineering part of the T cells, so from the collection to actually receiving them, can be 6 to 8 weeks. So you need to have a strategy to keep the disease under control, because the more disease you go in with, the more these T cells will get excited when they see the disease, and the higher grade of complications can happen. So we always want to bridge patients who have a lot of disease to bring that disease burden down, or at least stabilize things until those T cells are ready.
Okay, great. No, thank you. That's incredibly helpful. I think this kind of segues into a couple topics too as we kind of near towards the hour. One piece I want to make sure, also to focus on too are these kind of the considerations to keep in mind. So Jordan, this question is for you. What do you tell patients who, potentially are still debating if that is, a point into the process when they're debating between maybe CAR T and bispecifics, potentially thinking of proximity to a cancer center or time off, and of course, all these other support areas such as your caregiver. What do you share with them?
Yeah, so the CAR T process is generally going to mean kind of more of a bulk time off up front, either for patients and or their caregivers that they'll need to have with them 24/7. And then for the CAR T also, depending on the center where you are and kind of comfortability of patients and caregivers, the most of the time for the CAR T cells, you're in the hospital for a couple of weeks. We have the availability for some of our patients to do it in an outpatient setting where they're coming daily, staying locally, but it is more kind of time consuming, very upfront monitoring in those first, couple of weeks. And then even once you're out of the hospital, you have to stay very near to our center here for another couple of weeks. And so sometimes that just amount of time having a caregiver take off work, or some of our patients are still working themselves. And so having that that kind of bulk time is a big factor, I think, for people.
Great, well, thank you. And thank you, Jordan. And then Kim, you touched upon this nicely about kind of what made you decide. Can you kind of share a little bit more about the decision between CAR T cell therapy and bispecific? I know you talked about MSpikes, and we're seeing some comments in the chat about that. Yeah, that's
right. I did the 2 stem cell transplants, and I really had a hard time with the recovery on the stem cell transplants. Nausea, fatigue, not being able to eat for months after. I wasn't quite up to dealing with that again, and that's kind of what the CAR T cell therapy, it was told it's kind of like a mini transplant, and I was like, yeah, no, can't do that. So that's pretty much the reason why I went with the bispecific. I was not ready to confront all of that again, and when it comes to time that's the option I have to do, I will. But I really wasn't, with my son being in high school, and I really wanted to be more present, be at home, not having to take that bulk of time off and being, sick. And that was probably the biggest reason why I chose the bispecific, was just not having to deal with the mini transplant. I couldn't do that. So that's pretty much what, and the fact that, my end spike was up, and I really didn't want to wait the, 6 to 8, 12 weeks, whatever it would be, for the CAR T cells to get re-engineered. I was ready just to move on with treatment and get going into getting my end spike down and getting into remission. So that's pretty much, it's a very personal decision. It depends on a lot of different factors. It's a family decision. It's, are you working? Are you not? Do you have a caregiver? Can that caregiver be out of town? And I do want to say too, that the, what's the Hope Lodge there at Levine? Is it the charity? What is that?
Hospitality House.
The Hospitality House. If you have a cancer center that has one of those, that is the best place. I would be in the hospital. My husband would stay at the charity house. He would come over and visit me. When I was doing my step-up dose, I would be in the hospital for 2 days, and I would have a night with my husband at the Hospitality House. So huge. Always look into that, because that's huge.
That sounds great, Kim. Can you, or Dr. Varga, what is the Hospitality House at Levine?
Wonderful.
It's
a saving grace.
Yeah, it's actually in very close proximity to the hospital, and it's kind of like a hotel, but not really. It's I think it's, and Jordan, you can correct me, it's like $50 a night or $55 a night,
right?
It's something
like that. And there's sometimes, sometimes even the pharmaceutical company, like if you're getting CAR T and you live very far away, sometimes they'll even give like a grant to use for the caregiver to stay local. And I think, and I have actually not seen it, but I think it's more wonderful. Like a community type of setting where like people eat, in one area, one location.
Well, it's like
individual.
You have your individual hotel room. And then there's a living room, there's games, there's a huge kitchen with like 4 or 5 refrigerators. You can cook your own meal. While I was there, both with my transplant and then with the bispecifics, they have churches that come in and make food for everyone. Or you can make your own food. They have, washer and dryers. It's like a house, but you also have your private room with 2 double beds, a bathroom, and all that. It's a fabulous place. If people want to come visit you, they can come and you can have a meal at the dining room table downstairs. It's just a wonderful, and it's within, they have shuttles back and forth to the hospital. It's like a 10-minute walk from the hospital, but they have shuttles going back and forth. And we utilized it every time we've needed to. And it's just a fabulous, fabulous thing for myeloma patients or any patients that need it. It's definitely. I also wanted to shout out to the Leukemia Lymphoma Society, as well as copayrelief.org, for patients who are looking for any kind of assistance with payment of drugs or premium insurance. They have grants. And I have a grant with leukemia lymphoma, and they pay my secondary insurance premium every month. And it's just a huge help to myeloma patients. So I just wanted to let everyone know to check out those 2 as well.
Thank you. Well, thank you. These resources sound great and good for patients, at least to keep an eye out and see what resources are available for their caregivers, especially as they're going to be on these treatments. So that's great. Thank you both for sharing that. As we're kind of nearing to the end of the hour a little bit here. A question in the chat. So Dr. Varga or Jordan, either of you can answer this. So there is now the future of bispecifics. It's being provided for eligibility to earlier lines of therapy. So how well, or can you kind of share how well that patient group is responding, or maybe a few on information on maybe the clinical trials that have data surrounding that, just to kind of, an overview of what that performance is looking like right now in earlier lines.
It is definitely being looked at in earlier lines. There's tons of clinical trials. I can't go through all of them, but they're bringing them to earlier lines in combination with some of our immunomodulators like Revlimid and pomalidomide, and then daratumumab, and then combining it with all different combinations. And I have a patient that's on the combination of talquetamab, daratumumab, pomalidomide, dexamethasone in early relapse, and she's doing phenomenal. Like she's had a great response. So I think that bringing these to earlier lines, it makes sense because that's when T cells are the healthiest. So if we're leveraging the T cell system and these patients are not that heavily pretreated, it just makes sense that they might work better earlier. And especially if you're using synergism with some of our other agents. So I mean, the jury's still out. We need to see how well patients do over time, and it's important to see how they do on that present line of therapy, but it's also important to see how they do on their next line of therapy, right? So if we're using some of our best therapies early on, are we compromising anything later down the line? So I think all this is still up in the air, and we need to gather that data. But definitely, if you have a clinical trial in your area, definitely you can consider one of these, earlier CAR T therapies or earlier bispecific antibody therapies and get on them for sure.
Fantastic. Great. And that kind of adds me, at least from, turning over to the patient perspective too. Jordan, do you receive, or what advice would you share with patients who maybe are thinking about participating in a clinical trial or, considering that?
Yeah, I think, if you're not somewhere that has clinical trials, I think that it's certainly okay to ask to have a referral to somewhere that does have clinical trials. It doesn't mean that you don't feel like your oncologist is doing a good job or anything like that. It's just that there are so many new treatments that are available and coming available. And then, I think have discussions with either the doctor you're seeing locally, or if you get referred, just ask lots of questions, bring up any concerns you have. I think, of course, talking with your family about it too. I think clinical trials, we do them a lot here, so they seem like every day to us, but I think there's still can be a lot of, you hear clinical trials and it makes you worried, I don't want to be experimented on, that kind of thing. But these are all, we're not ever giving anyone a placebo drug or anything like that. These are all, things that have been thought about a lot, studied in, them getting to patients too. So I think just lots of conversation with family, with your doctors, all that kind of stuff, and ask as many questions as you have, because we don't want to put anybody on any treatment that they don't feel comfortable with. So I think, we're, always happy to answer questions about any of the trials or any of the treatments at all.
Fantastic. Thank you. Well, we're at a little bit close now to the hour. Before we close out, Kim, I want to kind of pivot it over to you. Do you have any kind of advice or takeaways that you can share with our audience regarding your experience recently with bispecifics?
Just be open to new treatments. Definitely having a great relationship and an open relationship between me and the nurses and both of my doctors, both with Levine as well as my local one. Be informed. I mean, get on these type of things. Get on the Facebook. There's tons of support groups. I don't go to one locally. I go to, like Facebook and all of that, and they're huge. I mean, I get so much information, And I feel like I'm helping other people just like they helped me when I was first diagnosed. First diagnosis, it's a horrible thing. Please don't Google. Just have that support group. Don't be shy. Just ask questions. Have your support group. Just live your life. It's not a death notice. Multiple myeloma it doesn't mean you're going to die in 3 to 5 years. It doesn't mean you're going to die in 10 years. You can go to work. You can have a fulfilling life and enjoy life. It's there to live.
Thank you, Kim. Thank you. Well, thank you. Well, thank you all so much. We're at the hour here. So on behalf of the MMRF, I'd like to thank Dr. Varga, Jordan Robinson, and Kimberly Odom for joining me today. I'd also like to thank everyone for taking the time out of your day to watch. If you joined us in the middle of this piece, that's okay. We will have a recording of this live stream up on the MMRF YouTube channel. And finally, I'd like to thank Adaptive, Alexion, BMS Cure, Genentech, Johnson & Johnson, Kite, Arcellx, Pfizer, Regeneron, and Sanofi for sponsoring this live stream. And if you have additional questions about what you heard today, you can always call the MMRF Patient Navigation Center, which is a call, email line that is staffed by 3 wonderful oncology nurses. And so you can ask more questions related to today's live stream. Their number is 1-888-841-6673. Thank you, everyone.
Thank you.
Thank you.